بسم الله. حالة طبية، كيس ديسكشن من خلالها بناقش حالة طبية اليوم، من خلالها لعلي أتوجه ببعض التبس أو النصائح أو educational points لزملائنا العاملين بأقسام الطوارئ، general practitioners أو ربما حتى طلاب الطب. الحالة اللي اليوم بنتكلم عليها هي radial nerve palsy radial neuropathy، تسمى بأسماء أخرى منها Saturday night palsy، honeymooners palsy، lovers palsy. ليش سموها lovers palsy أو Saturday night palsy؟ هي الحالة هذه عبارة عن حالة من الحالات compression neuropathy، compressive neuropathy، injury للradial nerve ناتج على compression نتيجة sleeping in awkward or abnormal position leading to the injury neuropraxia or injury للnerve which will lead to the motor impairment or sensory impairment or both. ليش سموها Saturday night؟ لأن patient at a Saturday drinking alcohol become intoxicated or under influence of drugs and then sleeping in abnormal position, which usually in this case sleeping at the edge of the chair, compressing at the level of axilla. تسمى بالهانيمونرز أو lovers radial nerve palsy لأن الهانيمونرز they sleep on beloved arms, so causing compression to the nerve leading to the radial nerve palsy. وربما تحدث نتيجة ما يسمى أيضا بالكراشز nerve palsy. الكراشز أو الناس اللي يستعملوا في الجيلات خصوصا اللي على مستوى الارم بيت causing compression neuropathy leading to the radial nerve palsy. مريضنا اللي جانا هذا لم يكن intoxicated or drinking any alcohol or drugs، ما كانش في الهانيمون. He was working as a night shift sitting in his table and then wake up. He presented to our clinic, urgent clinic, at 5:30 a.m. morning, and the chief complaint was unable to extend his right hand, unable to extend the right finger. So he presented with the wrist drop of the right side, right hand, and paresthesia and numbness over the dorsum and lateral side of the arm. Patient deny any trauma or fall, deny any fever, there is no abdominal pain or vomiting, no headache, no diplopia, no blurred vision, no syncope or near syncope. Actually, when his friend wake up him at 4:30, he did not notice anything until he's trying to open the car using the car keys, and then he find himself unable to perform this task because of the hand grip was weak, unable to extend the hands. So he came in with what we call the classical presentation of radial nerve palsy. Patient he will come holding the affected hand by the normal hand, saying that he unable to extend the wrist, unable to extend the finger. من هنا نبدأ في النصائح. The first tips is number one priority for you in emergency department is you have to rule out stroke, because the stroke is a time sensitive disease. Time is brain, and you might still under window of activation stroke unit, and then you have to rule out stroke by focused history and physical examination, which will be thorough CNS examination. شنو هو thorough CNS examination? You start with the screening test for the stroke, so using the VAN. You assess the verbal patient speech, looking for the aphasia, or assess slurred speech, assess the patient's speech, verbal, and assess if there is any pronation drift, and facial symmetry. And in your thorough CNS examination, you have to test and document cranial nerves from 2 to 12. It has to be documented and tested. And then power and tone and reflexes and sensation, upper limb and lower limb, right and left. It has to be documented. And then coordination using the finger nose test, or what they call batty cake test, or alternate movement. Chin lift, this might be extra here, but at least do 2 of coordination test. And then you test for clonus, and you test or look for Babinski sign and reflexes. When you assess the muscle, either in this case, focusing on extensors muscles and triceps and brachioradialis, also generally any muscle assessment you have to grading using the grade system from 0 to 5, whereas the 5 is muscle against resistance, functioning of the muscle against resistance, which is normal 5, until 0, whereas there is no even contraction. So that's why whenever you test, you palpate. And the CNS examination never finished without assessing the patient gait and do Romborg sign. Ask the patient to stand up, close his feet together, and close the eyes because you want to eliminate vision. Because you are testing in this Romborg, is you are not testing cerebellum like coordination, you are testing the proprioception. So for that reason, you have to ask the patient to close his eyes. Our patient was walk into the clinic unaided, gait is not disturbed, he was afebrile, not in any distress, of course alert, oriented, GCS full 15/15, and cognition was normal, afebrile as we mentioned, vital signs within normal range, dextrose was normal, and then CNS examination was completely normal except for absence of gag reflex. We know that might be normal for normal individual, and also the wrist drop, unable to extend the wrist of the right hand, unable to extend the fingers, and also unable to extend the thumb. The grip was noted weak when is the patient in the flexion position, but somehow stronger when you fix and ask and put the extended hand, pronated, and eliminate the gravity. The sensation, as I mentioned, in the sensory nerve innervation of the radial nerve at the first interdigital space between the thumb and index finger, it was reduced compared to the normal side, but still preserved. Still there is a sensation. You do not forget to test for fine touch and also for needle break test. And so in this our examination, we already have ruled out any evidence of stroke. Here now we can go for thorough history. History, you have to look for causes such case, because we know the causes might be due to trauma, so the patient does not have any history of trauma or fall, no heavy lifting, no repetitive movement. And then there's, because you know the fractures and surgeries is a common cause to cause this problem, but there's no history. And then cervical neuropathy, patient does not have any neck pain. They have neck pain, they usually get relief of the symptoms if they do this movement, but this patient have no neck pain, and there is no such movement or relief. There's no fever that might think of any infectious disease or coming from areas that when you think of some Lyme disease or whatever, there is no evidence that could lead to lead poisoning, because lead poisoning is one of the causes. Lead poisoning, but they usually present with the vomiting, abdominal pain, and usually it's not focal. So here you have, when you ask further, the patient said that he was traveling the whole day since morning from his hometown in India, travel by car around 1.5 hours, and then domestic flight to the main city, the capital city, 2 hours flight, 4 hours flight from the city to that city, to the Doha airport, and then further land transportation, further flight, further land transportation, and end up arriving to the workplace where he have to work night shift, sitting on the table, tired, lack of sleep, fatigue, and he sleep in awkward position, what he was describing as in this position at the edge of the table, until his friend wake up him 4:30. So now you have come up with diagnosis, which is a radial nerve palsy. Now, the important things that you do is you have to test for the triceps. The triceps was normal, power 5/5. Triceps function is actually extension of the elbow against resistance. And also you have to test the triceps reflex was symmetrical bilateral. And then you have to test for brachioradialis. Brachioradialis test patient have to be mid pronation position and flex the elbow against resistance. And as we always said, you try to palpate the muscle. So the only motor impairment was that this patient is extensor group muscles, where he unable to extend the hand and unable to extend the fingers, unable to extend the thumb. The grip and flexion position was weak, but it's stronger when you eliminate gravity and extend passively extend the wrist. الخطوة الثانية المهمة بعد ما انك انت rule out stroke و rule out other causes وعرفت ان هي radial palsy or most likely the diagnosis، هنا تجي مهمة communicate well with patient, explain to him the prognosis. Especially important that he has to know the recovery might take time, usually starting from 4 to 6 weeks up to the 4 to 6 months. Physiotherapy is the important, and then the next step is that you have to construct a splint using some splint or any type of splint that to put the patient. First of all, it has to be at the MCP joint, allow free movement of metacarbophalangeal joint. And then make sure that the thumb is free also for the physiotherapy purpose. You have to do passive extension. And then put it in minimally 20 degree of extension of the wrist joint, even advisable up to the 90 degree. Put the bandage, and very important to ask the patient to keep wearing this splint the all time, except for the hygiene purposes. And then teach him about the passive movement of physiotherapy, refer him to physiotherapy. And also you have to remember, if there is complete paralysis, sensation and motor, it will be urgent referral as soon as possible. But if there's in our case, sensory impairment and most likely diagnosis a radial nerve palsy, so this patient can continue physiotherapy as long as he's wearing the splint plus minus vitamin B complex, I think. And then this patient might need to do nerve study, especially if it is 4 weeks with no improvement. But the most important is physiotherapy. شكرا للاستماع، وإن شاء الله تكون في فائدة في هذا الفيديو، والسلام عليكم.